It's a real honour to be described as young. Certainly at home, when I stand up, everyone rolls their eyes and says, "Not her again," because I do like to talk. Now, my first thing, I've got actually one starting slide. So I was experimenting. I've been quite rigid with my slides for a long time, and I'm very stuck on a bold red title and black text and the Calibri font. I've been very attached to the Calibri font for a long time, and I've spent a long time experimenting with new fonts, and I found a new font called Osaka on my Mac. But it's corrected to what I think might be Arial, so I'm really sorry for using Arial font, because it's one of the ones that I find quite offensive. But anyway, I'm going to be talking about the clinical considerations for long-acting antiretrovirals. So, I'm going to cover whether they work, what are some of the advantages potentially, but also what are some of the concerns. And I'm focusing very much on what we have imminently, and we'll be hearing more in the next talk about some of the exciting pipeline developments. So I think the first question is, do injectables work? And really we don't have efficacy data for everything, so some of this is about pharmacokinetics, but when we're looking about do we get the drug levels we need, and where we've looked, do those drug levels achieve what we want them to do? This is the main summary. So if we look at HIV treatment, we're looking at injectable cabotegravir and rilpivirine. So we've seen the results for LATE-2, which I will show you, which is a phase 2 study. And then we've got 2 big phase 3 studies of the same regimen, FLAIR, which is for treatment-naive people, and ATLAS, which is for people who are undetectable on treatment already. And I think we're going to be seeing preliminary results of those at CROI next year. When we look at pre-exposure prophylaxis, intramuscular rilpivirine was discontinued last year, and that was after data presented at the IAS conference, which demonstrated inadequate female genital tract PK, and when they looked at cervical tissue explants, inadequate viral suppression. Prior to that, there'd been a single-dose study which suggested the PK would not be good enough in women, and last year we saw the multiple-dose study showing the same, so that was discontinued. In terms of what is continuing for injectables, IM cabotegravir is being studied as a single drug for PrEP. There's 2 phase 2 studies, ECLAIR and HPTN 077. We've seen no efficacy data for those yet, but we have seen some PK and some acceptability data that I'm going to show you. In terms of what's going to be coming further along, there are 2 large phase 3 HPTN studies looking at IM cab, one in men who have sex with men and transgender women, and one in cisgendered women. So those results are all going to be coming up over the next couple of years. So looking first of all, HPTN 077. So this is a study looking at 2 different injection regimens. So the cabotegravir versus placebo in both with an oral lead-in phase, and that's something we'll come back to later. And one is of an injection every 12 weeks and one of an injection every 8 weeks. Now, the follow-up has been extended from the original study design, but what we know so far, so we do not know about the efficacy yet. We don't yet know if this is going to work as PrEP in this study yet, but what we do know is that it was the second cohort. So this is the injection every 8 weeks and not the injection every 12 weeks that met the PK target. So that's the dosing we're going to be looking at going forwards, an injection every 2 months. We're going to learn much more from these 2 studies, as I've mentioned in the list. I'm not going to go through the study designs in any detail. They're just in here because you'll have the slides afterwards and just as a reference point. But 083, as I mentioned, is in men who have sex with men and transgender women. And then 084 is in cisgendered women. So again, those results will tell us much more about the efficacy. Now, in terms of what we've seen so far for HIV treatment, we've got LATE-2. So LATE-2 is a study with an oral lead-in. Is in people who are naive to antiretroviral therapy. They were excluded if they had hepatitis B, and of course that's important. Sanjay mentioned early this morning the importance of hepatitis B in terms of using dual regimens. And essentially, what happened after the induction, people who were suppressed after the induction on oral cab with an abacavir 3-TC backbone were randomised either to continue that oral cabotegravir-based regimen or to switch to one of 2 different doses of cabotegravir and rilpivirine injection. So you're stable on cabotegravir, and then you either stay on that oral regimen or you switch to injectable cabotegravir with rilpivirine. And these are results out to 96 weeks. And essentially what we're seeing here is high rates of maintained viral suppression. So you can see everyone is suppressed to enter the second phase with the injections, but with both injection regimens and with a continued oral dose, high rates of viral suppression out to 96 weeks. So this is telling us that it's looking promising in terms of efficacy. But we're going to need bigger studies to really answer the efficacy question. So again, I won't go into these in any great detail. They're there for your reference, but I mentioned the FLAIR study in treatment-naive people. And again, this is a study with an oral lead-in and then randomized switch to injectables or continued orals. And ATLAS is a very similar study, but in people already suppressed on treatment. Now, one of the things that probably one of the most presented slides from LATE-2 is what it's shown us about patient preference. Because I think prior to the injectable studies, if you ask most clinicians, do you think your patients would rather take tablets or have injections? Certainly most people I spoke to would say tablets. I mean, who wants an injection? But this is quite surprising, because what this showed us, if you look on the left, these are people getting injections every 4 weeks, the middle every 8 weeks, and the far right are people on the oral combination. And this is a question after 96 weeks of how satisfied would you be to continue your present form of treatment? And the pink colour is people who'd be very satisfied to continue. So you can see most people on injections would be happy to continue their injections, whereas fewer than half of the people on tablets felt the same way. So there's a clear preference here in participants of LATE-2 for injectable treatment. But I'm going to pose a question to you all. Do you like Celine Dion? No. It's quite a small number. Now, I want to imagine asking that same question if I was at a Celine Dion concert. I think more people would put up their hands. And it's a slightly silly example, of course, but the point being, people who've entered an injectable study are already prepared to have injections. So in a way, what we really want to know is more from the general population, people who haven't entered an injectable study. Now, this is one such study. This is small, but it's a very in-depth qualitative study. It was an in-depth interviews with 28 people with HIV. So this is to illustrate two things. One is the population that you ask. If you ask people in an injectable study, they're probably going to be quite keen on injections. But it's also where you couch that question in the context of everything else that's important to people with HIV. Because if I say injection once a year versus tablets every day, people probably are going to say injection once a year. But if you say what's most important in terms of in that hierarchy of needs and that hierarchy of desires as someone who's going to be taking treatment for life, what's most important to you? Now, what this study showed is actually it was the clinical attributes of a given drug that were most important to these patients. Controlling the virus, possibly curing the virus, minimising organ damage, improving CD4. Those categories got the highest individual scores and the highest group scores. And what I've highlighted down the bottom is the importance of long-acting in this particular study. Now, again, this is small. I'm not saying this is true for everybody, but it just emphasises who you ask and how you couch the question is very important in terms of what the answer might be. What about PrEP? Now, this is data from HPTN 077, so the same caveat that these are people who've entered an injectable PrEP study. And what you see here is that orangey colour. Most people preferred injections compared to other choices which included vaginal or rectal gel, vaginal ring, or daily tablets. The difference between the two, on the left is people in the US and on the right is non-US participants. You can see quite a striking difference, but the same pattern. The majority of people in this injectable PrEP study preferred an injection. Excuse me. Now, what about people who aren't actually in one of these studies? Now, this is quite an interesting one. This is TRIO. Sorry, I'm just going to have to have a quick drink. I apologise. Yeah, no. Yeah, if anyone's mean to me, you know what I'm doing. I'm a great actress. Right. So, the TRIO study, this is an interesting study. It was all placebo. And people in this study, and they were all 18 to 30-year-old women. It was about 100 people in the study, as I remember. But what they did is, stage one of the study, they all had a month of 3 different placebos. Tablets, a vaginal ring, or an injection. This is all placebos, no active drug at all. So you've got these young women, they have a month of each. After 3 months, they're given the choice of what method you want to continue for another 2 months. And then they studied the results. Now, the first thing is 85% preferred their tablet or vaginal ring or injection over condoms. So these methods were all more popular than condoms. But, perhaps not surprisingly from what we've seen, most preferred the injection over tablets or the ring. So injection was more popular in these people who tried a month of each. And this is how they ranked them. So the lightest grey is number 1, so that's where they ranked that product first, and then you go further down. You can see injections are the most popular, then it's pretty close between tablets and ring and condoms. Oh, I'm missing. Oh no, sorry, come on to that in a moment. So I'm going to come back to the overarching question of why do we want to consider injectables? And this is a list, and it's not exhaustive, but if we go through each, I think patient preference, certainly the data we do have would suggest that yes, patients may prefer injections. Again, I don't think we've had any large-scale questionnaire surveys in people who aren't participating in trials, but certainly what data we have thus far would suggest patients prefer it. There's certainly the argument about less dosing, and so people suffering from pill fatigue, or particularly people who have difficulty swallowing, then clearly having a regimen where you don't have to swallow tablets may be advantageous. Fewer drug interactions, I think that's taken as granted. More privacy, I've given it a tick, but I'll come back to why perhaps that may not be the case. Less drug exposure, and if we agree that less drug exposure may mean less toxicity, then that's likely to be a good thing. But ultimately, there's this question about whether or not it prevents poor adherence. That's something I'd like to explore a little more. So adherence is still important. We used to talk about having to have at least 95% adherence in order to maintain viral suppression, and 95% adherence is still the threshold that's often used in trials where they report results by adherence, which they don't always do. So I've taken 2 recent studies, 1489 and 1490. These were trials in naive patients comparing Biktarvy with dolutegravir-Descovy in 1490. These are the wrong way around, I apologise, or against Triomec in 1489. And the point I want to make here is the less than 95% adherence is the reddish colour. And what you do see is a small drop-off by regimen based on adherence. Now, across study arms, that difference is not significant. So the difference between Biktarvy and Triomec, for example, are below 95% adherence. The difference between them, there is no difference. What they haven't analysed statistically is whether the drop-off is statistically significant or not, and that's something to consider. But there is a difference. Now, there are confounders. The numbers are relatively small. Is this a marker for a more advanced HIV, etc., etc.? But this does highlight, even with very modern regimens with long half-lives, all those things, adherence is still important. When it comes to PrEP, we know adherence is really important, and a number of the studies in Africa, particularly in heterosexual women, showed that in some situations people just were not taking the PrEP at all. And this is taken from a presentation at IAS this summer, and this is summarising a couple of the heterosexual oral PrEP trials. And what it's showing is if people take their pills every day in these PrEP studies, you get good protection. If you drop to 4 pills a week, the protection starts to drop, but particularly for women. So you can see here 4 pills a week, 61% efficacy. If you go down to 2 pills a week, you can see actually still reasonable efficacy for men, but vanishingly low efficacy in women. And really the PrEP studies are fascinating because they've really shown a huge divide between what people say they're taking and what they're actually taking. The studies that showed really high adherence based on self-report showed very low adherence when you looked at drug levels, and there was a real marked difference. So when we look at adherence in trials, we know, particularly in the PrEP studies, that adherence to your trial visits doesn't necessarily mean you're taking your medication. You'll pitch up, you'll have your blood test, you'll smile, you'll say you're taking your medication, but you may not be. But clearly for the injectable studies, we know that people are taking the medication because they're having the injections at the visit. So, of course, we can be confident that adherence is 100%. So what about in trio and adherence in trio? And a trio, again, to remind you, that was a study I showed you where young women got 3 different types of placebo, pill versus vaginal ring versus injection. And actually for the women taking tablets, they used Wise Pill. And Wise Pill is a bit like a MEMS cap or something like that. It's an electronic thing that tells the investigator when the bottle has been opened. Again, that doesn't necessarily translate to taking the pill. People could still open it, of course. And they considered you adherent if you opened your pill bottle for at least 80% of the days that you were supposed to. Now, what they did show, and again, not surprisingly perhaps, is stage 1 adherence to the pills was better in people who chose to stay on the pills. So people who preferred pills were more likely to take them, and that kind of does show that patient preference may be predictive of adherence. And let's look at what that adherence was. So at the visits, they took the first and last tablet in the clinic. So not surprisingly, this is directly observed therapy, very high rates of adherence when someone's watching you take the pill. Self-report, it goes down a bit, but it's still not bad. 75% of these participants said they were taking their pills. But what did Wise Pill tell us? Much, much lower. So despite 75% saying they were taking their pills, actually in stage 1, taking the pills for a month, it was 30%. In month 4, these are people who chose to stay on tablets, it was 20%. And month 5, just 2 months into choosing to stay on tablets, it was just 10%, a statistically significant decline over time. When we asked them about, well, how interested would you be in using that product in the future, you can see a big difference here as well. It's much higher for injectables. But still 57% for tablets, despite the fact that people who chose to be on tablets just weren't taking them. This, to me, is one of the real mysteries of PrEP adherence. But I think the million-dollar question when it comes to adherence is, with injectables, what's going to happen with delayed or missed doses of an injection? Now, we know a little about this from ECLAIR. So again, ECLAIR is an IM cabotegravir PrEP study. This is in men who have sex with men who are at low risk of acquiring HIV. And there are no efficacy results yet. But what I want to show you is the PK. Now, this is looking at the PK over time. So one thing they've learned from this study is actually you achieve levels quicker than expected. So you absorb this quicker than expected. But that's not the bit I'm particularly interested in. It's this bit. So these men had the injections, and then they stopped the injections, and then they measured concentrations over time. And for me as a clinician, I think these tail studies are so important. And the tail studies looking at oral regimens, you know, if you stop a tripler, what happens to the components over the subsequent days? If you stop Eviplera, looking at the integrase inhibitors, because it's that sort of data that helps us answer the question, you know, I've missed 3 pills, do I need to be concerned when patients ask us? But what this shows, I just want to draw your attention to the bar over on the far right, is that 17% of the participants still had detectable drug 52 weeks after the last cabotegravir injection. So much like we know about rilpivirine can persist for a very long time after an injection, the same is true of cabotegravir. And the question is, how are we going to manage that clinically? And that's an answer I don't think we have yet. So rilpivirine tail we know is also prolonged. Just to give you a couple of examples, in one single dose study, rilpivirine, this is in women, rilpivirine was detected in all of 7 samples, a mean of 541 days after the injection, so more than a year later. And certainly in the MSM rilpivirine PrEP studies, there was a case of resistance in an MSM exposed to HIV 40 days after a single dose. So we know that rilpivirine has a long tail as well. So that's going to bring me on to some of my concerns. So I think my first concern when it comes to injectable treatments is safety. And yes, at the moment we're having oral lead-in phases, but we know, what about delayed onset toxicity or emergent safety concerns? And actually we know for a lot of drugs, and in a way the safer a drug is, then the more delayed any emergent event is going to be. It may be unlikely, but if it's going to emerge, it can be several years of post-marketing before that thing is detected. And think about the discussions we've had this morning around dolutegravir and pregnancy. Imagine if that pregnancy signal, instead of happening in the era of oral dolutegravir, happened post-rollout of injectable cabotegravir, and managing the concerns of patients who already have this drug in their body and there ain't no quick way of getting it out. And certainly, if you look at the HPTN 084 study, and again, this is the PrEP study in women, they're taking it very seriously, and all the women have to be on long-acting contraception. There's a pregnancy test prior to every injection, and that's really all you can do, I guess. The other issue is injection site reactions, of course, and I don't think these are trivial. So this is from 077. I've chosen cohort 2 because that's the dose that's going forward being studied, but actually cohort 1 was fairly similar. And what you have here, each block of bars is after each particular injection. So we're going from injection 1 through to injection 5 from left to right. And each pair, on the left are people getting the active injection, on the right are people getting placebo. So what you can see is you inject someone with anything, you're going to get an injection site reaction. That's not surprising, but the injection with the active drug is much more in terms of injection site reaction reports than the placebo. There is perhaps a suggestion that it might get a bit better over time, but it's still pretty high rates of injection site reactions. And really how tolerable that's going to be over a long period of time, I think, hasn't been addressed by any of the trials yet. And it's just it's not just non-injection site reactions. So if you consider the fact that overall you're going to get sort of lower drug exposure potentially with injectables over time, there are still side effects from these drugs. And what this shows us here, again from HPTN 077, with pale grey for cabotegravir injections and the dark grey for placebo, injection site pain significantly higher on the active drug, which we saw in the previous slide, but also headache, which we know is a potential side effect of integrase inhibitors, significantly higher. Drug-drug interactions, now these are markedly reduced, but they're not eliminated. We know that injectable drugs are still subject to drug-drug interactions. Rilpivirine intramuscularly, for example, may be a victim of CYP3A4 induction or inhibition, but we don't really have much data, because if you think of the effort that goes into designing a pharmacokinetic study for oral drugs, it's a whole different level of complexity when you're looking at injections with very long tails of the medications that are administered. So I think there's a lot of debate at the moment about how best to design studies that are going to address potential drug-drug interactions with injectables. For me, coming from the impoverished UK, I think the cost and visit frequency is the thing that really makes my head spin. So all of us everywhere are needing to do more with less. And I think it's fair to say that most trial participants receive a really gold standard clinical experience. You have generally more frequent visits. Certainly where I work, you've got a much higher nurse to patient ratio within the trials than you do in our NHS clinic. And we are living in a bit of an era of austerity. And so really, are injectables realistic? As with the success of our oral treatment has meant that we can offer people less frequent visits, less intensive monitoring. We often do virtual monitoring now for our patients. They pop and get their blood test, then we phone or email them. It saves them a visit. It's convenient. It's easy. Are injectables, in some regards, a backward step when it comes to the patient experience of coming to clinic? So here, often when I have these questions, I ask what would Jose Arribas do, but he wasn't around, so I had to go for second best. I had to ask Professor Pozniak. And this is Professor Pozniak's mathematics. So he worked this out. So with oral treatment, imagine you've got 1,000 stable patients and they're coming twice a year for tests and meds at 30 minutes per visit. This shows that Anton doesn't spend enough time in clinic, because 30 minutes in an English HIV clinic is a dream. By the time they've waited to queue up at reception, wait at pharmacy and wait for someone grumpy to do their blood test, it's often a lot longer. But anyway, in Anton's ideal world of 30-minute visits, that's 1,000 clinic hours. Now, if we go to an injectable, imagine we're having an injection every 2 months, you've got 1,000 stable patients coming 6 times a year for tests and meds, 30 minutes, again, optimistic, 3,000 clinic hours. So just simply there, the amount of time in clinic, not just for the staff, but the patients, is going to be dramatically increased. So there's the time, there's a frequency, there's a fact that actually at home people like their virtual appointments. Now, I'm not saying virtual appointments are good for everybody. We make sure we've got mechanisms people can come back in. But for people who are well, it really helps normalise HIV for them that we can manage this in a virtual manner. And clearly you can't do virtual injections. Now, I'm going back to that point I made earlier that people say if you're not taking tablets every day, that's good for stigma and confidentiality. But I'd flip it the other way and say if you're coming to an HIV clinic every 2 months, is that really going to be necessarily good for all people in terms of their stigma and confidentiality issues. And then there is the staff time, the booking the appointments, but chasing people who don't attend their appointments. Doing that 6 times a year instead of twice a year, I think, is a potential minefield. And actually this comes back very much to what Pedro said earlier, and I promised I wrote this slide before you gave your example. So I think this first example, who are injectables best for? And really it's going to be highly adherent individuals with free time. So this is your patient, isn't it, who comes in worried about taking his meds an hour late. Again, people already engaged in regular prescribing or support services. So you talked about people with key kind of support workers or relatives. And again, people perhaps on opioid substitution programs, or people receiving depot antipsychotics or another form of directly observed therapy, where you can slot those injectables into an existing care package, then I think that could be really effective. But when we first started talking about injectables, the recurring theme was this will be great for poorly adherent patients. And I think it's the worst thing for poorly adherent patients, because people who don't take their meds tend to not come to clinic either. That is a sweeping generalisation. I know it's not true for everybody. And also the other example is when people are really sick and they're in hospital, they can't swallow, they're on dialysis. Perfect. But is it going to be perfect if someone comes in sick to hospital and hasn't had an oral lead-in? Are you going to risk giving them injectables of drugs they've never seen before for the first time? So actually 2 of the scenarios that were being discussed early on, I think, are actually the 2 very scenarios where it may be hardest to use injectable treatments. And it's not just about the people and the drugs, it's this storage. Let me just highlight this. Cabotegravir is pretty good. You could probably carry it around in your rucksack for a year and be absolutely fine. But look at rilpivirine. You've got to store it between 2 and 8 degrees, and it can't be above 8 degrees for more than 24 hours. Now, at home, everyone says we don't have access to PrEP. We do have access to PrEP in a big trial. It's called PrEP Impact. And as part of that, we're using generic tenofovir disoproxil with emtricitabine. And actually the storage instructions for this generic are slightly more flexible than the branded, but you can't go above 30 degrees. We think that's absolutely fine. We live in England, that's not going to be a problem. We had more than 20 situations where pharmacy stock cupboards have gone above 30 degrees over the summer, and the drama that ensued, imagine that with much tighter temperature controls. I think it's going to be, I'm not saying it's impossible, of course it's not impossible, but it's not necessarily easy. And then when it comes to cost effectiveness, this slide also comes from a presentation that Anton gave earlier this year. This is US data. I won't go into any detail because clearly cost effectiveness depends on the other costs and they change a lot, particularly of the drugs. But the message really is that the price at which it becomes cost effective is lowest for first line treatment, for the easy treatment, and actually you can get away with a higher cost, so the cost effectiveness threshold is lower if you're looking at multiple experienced people. And really what the authors concluded in this study is if long-acting antiretroviral therapy has a high cost, it will be best used by targeting patients with a history of suboptimal adherence. But that's the very group that I, and I think judging from the nods in the room, we all think may not be the ideal group. And actually, I've put this in, what would NHS England say? When we had some initial discussions about the Advent, it was a massive no. Why? As soon as they just, so that's another, as Margaret said this morning, we've got to get Biktarvy first before we start worrying about the injectables. So in conclusion, I think, what do we know now? So injectables work in that the PK data and limited efficacy data we've seen to date show that they work. They're preferred by patients, but whether this will remain the case in real life and longer term, I think, does remain to be seen. And we're going to need to cover those drug tails for a long time, and the question is going to be how long. So that's going to move me on to the unknown. So I think, again, the drug-drug interaction issue is a question for people with more pharmacological brains than mine, but I think there's going to have to be some pretty clever study designs to address that. How long do we cover that PK tail for? I mean, is it going to be a blanket 1 year? Is it going to be based on drug concentrations? Do we measure the concentrations after 3 months and 6 months and decide when you can stop the oral drug that's covering the tail if you stop it? And of course, if you're going to rely on measuring drug levels of the injectable, you can't use the same drug as oral. So if you've been on injectable cabotegravir and you want to know that it's gone, you certainly can't be on the oral equivalent. The same is true of rilpivirine, of course. And again, the PK and experience in diverse populations, and we've heard a lot this afternoon, women, pregnancy, breastfeeding. What about people who are underweight? And that data I showed you that showed that a significant percentage of men still had detectable cabotegravir 52 weeks post-injection, that was more likely at higher BMIs. So you're more likely to have persistent drug at a higher BMI. When it comes to injections into the buttock, what about people who are underweight? What about people with lipoatrophy? And as a sexual health doctor, if someone comes in and has IM cabotegravir in their buttock and 2 days later needs benzathine for syphilis, this might be a stupid question, but I don't know. Can you put an eye injection on top of an eye injection? I mean, we just don't know. So really, I think when it comes to long-acting treatment, it's stepping stones. And I think there are a lot of issues with these relatively short-acting injections. But I think we're here, and I don't really think we're going to be using injections that we give every 2 months in 5 years' time. I think it's just a step on the way to cleverer and more intuitive long-acting formulations. So what do we need in the future? I think we need longer-acting injectables than we have at the moment. I think long-acting orals, of course, there's a lot of work going on there. But really, I think what we're going to need, I'm going to go far, far into the future here, intelligent implants. Right, this is what I'd like. So what I want is drug release from an implant that's adjusted to plasma concentrations as that implant measures the TDM in the blood. I want that option for immediate shutdown without removal when a prematurely released safety concern perhaps alarms everybody, for example. I want in that implant automated viral load and maybe a bit of safety monitoring, a little bit creatinine, who knows? I want individualised concomitant medication in the same implant, depot contraception, for example. And as a sexual health doctor, my dream implant monitors syphilis serology and gives that person a dose of benzathine straight from the implant when they need it. So I'd like to...
The NHK will say no.
So I'd like to thank Anton and Marta and also Jean and Paul from Vive for sharing their slides. I shall finish there. Thank you for your kind attention.